So if the moderator could please come ahead and do the introduction because we've already gone live. Thank you.
Welcome to the session on challenges for integration of home-based records into health systems. We are happy that you could join us. Let me present myself. I'm Anshu Jain, the Director for the Department for Maternal, Newborn, Child and Adolescent Health and Aging here in WHO in Geneva, and I will be the moderator for this session. As you are aware, in 2018, WHO released a global guideline on home-based records for maternal, newborn and child health. Home-based records range from antenatal notes or vaccination-only cards to more expanded vaccination plus cards, child health books or integrated maternal and child health books, which often include a record of health information as well as health education messages. The use of these records is intended to complement records maintained by health facilities. While different types of home-based records have been implemented widely in at least 163 countries, evidence of their benefits for maternal, newborn and child health had previously not been synthesized. Through the WHO process for guideline development, several reviews were conducted to look at, first of all, evidence on impact of home-based records on key outcomes. Secondly, at women's and caretakers and health workers' appreciation of home-based records. And thirdly, at issues related to implementation of home-based records. Two important recommendations came out of that. First, the use of home-based records as a complement to facility-based records is recommended for the care of pregnant women, mothers, newborns and children in order to improve care-seeking behaviors, male involvement and support in the household. For maternal and child home practices, for support in household, maternal and child home care practices, infant and child feeding, and communication between health providers and women and caregivers. Secondly, there was also sufficient evidence available to determine if any specific type, format, or design of home-based records is more effective. Policymakers should involve stakeholders to discuss the important considerations with respect to type, content, and implementation of home-based records. The guideline development group arrived at these recommendations and noted additional learnings from this process, such as, first of all, the weak and dispersed evidence base where desirable effects did outweigh any undesirable effects. Secondly, qualitative evidence reports that women caregivers and providers from a variety of settings value different forms of home-based records. And thirdly, in remote and fragile settings where health systems are weak or where health information systems are absent or poor, and in locations where caregivers may use multiple health facilities, home-based records may be of greater value than in more developed settings and health systems. It was clear that in order for home-based records to be effective, the quality, use, and availability of home-based records had to be addressed. Subsequent to the release of the guideline, WHO, UNICEF, and JICA signed a memorandum of cooperation to work together to support strengthening the implementation of home-based records. And more recently, in July of this year, a global coordination mechanism has been established, Global HBR, with the following objectives. Establish a global coordination mechanism, Global HBR, to review, monitor, and support implementation of home-based records. Secondly, to promote innovative approaches for implementation, including digitization. And thirdly, to share learning and knowledge to inform and enhance optimal uptake and utilization. Through this platform, key global partners have started to meet to discuss key issues and how to more effectively coordinate efforts to support countries. We have an interesting panel today to discuss some of the key challenges in integrating home-based records. I will introduce each panelist before they speak, but here is a short overview of the session. First, Ms. Keiko Osaki of JICA will set the scene for the session and highlight the mismatch between expected home-based record functions and actual home-based records users' capacities in the context of health system strengthening. Then we will move to a session of country reports. Dr. Collins Tabu of the Ministry of Health of Kenya and Dr. Suparni of the Ministry of Health of Indonesia will provide the audience with experiences from their respective countries related to the operational realities of implementing maternal newborn child health home-based records. We will then hear some global perspectives from Dr. Louis Pearson of UNICEF and Dr. Aiga of Nagasaki University. And then we will have some questions for our panelists and open the floor for discussion. But before starting to make sure that you, the audience, are engaged, we'll have a first poll question for you. And this first poll question is, in your country, are women and families encouraged to bring a home-based record to every health encounter? I'm going to give you 1 minute to fill in the poll, and we will then share the response and proceed with the session. So I can see that the majority of countries do recommend this. The figure is increasing, 88 to 89, 91% now. So I think we can conclude from the poll that what we see is that most countries actually actively encourage mothers and pregnant women to bring their home-based records on each and every visit that they have to the health facility. And so therefore, I think we should now go into the sessions and look at some of the issues that we have encountered. And so I go over to Keiko Osaki from JICA to give her presentation. And Keiko has already more than 10 years experience of working with home-based records in 10 countries in Asia and Africa. And she has published several articles on home-based records in international journals. So it will be a pleasure to hear from her what she feels are the gap between the expected functions on home-based records and what is actually being done at the field level. Over to you, Keiko.
Thank you, Anshu. I'd like to share my slides. Please allow me to share the slides. Thank you, Anshu. We have several times discussed on home-based records for maternal, newborn, and child health. At the first Global Symposium on Health Systems Research in Vancouver, fragmentation of home-based records were an issue, and the needs of consolidated efforts for having home-based records in health systems were called. After having the WHO guidelines in 2018, discussion on effective use of home-based records are needed more than ever. Today, I'd like to talk about filling a gap between expected home-based record functions and home-based record users' capacities. To understand inadequate use of home-based records, I will try to see gaps between expectations to home-based record functions and home-based record users' capacities, and would like to present a hypothetical diagram for better designing of home-based records. According to the guidelines, nearly every country used home-based records, but very differently and across countries and within countries. Inadequate use of home-based records, such as it is not precisely or not enough recorded by health workers, it's not be taken to health services or lost by clients, or it's not perfectly well understood by clients. Those have been often observed. Why such inadequate use of home-based records take place? We think the poor use of home-based records might be attributable to a mismatch between their expected functions and the reality of users' capacities to manage the home-based records. To estimate the relationship between capacities of home-based record users and home-based record functions, we reviewed studies on various types of home-based records. Types of home-based records are including maternal health cards for pregnant women, for pre-post delivery and between pregnancy period, for child period, immunization cards, growth chart cards, separately, but sometimes it's combined as a child booklet. MCH handbook, as its name tells that, it covers all MCH stages in an integrated format for pregnant women, mothers, caregivers, and families. Users are health workers and their clients, including pregnant women, mothers, and caregivers. We set functions of home-based records into 3 levels. First, data recording and storing function is to make individual MCH-related data available at home and mobile. Second, behavior change and communication function is to be home references and a prompt for upcoming care, and communication media between mothers, health workers, and caregivers. Third, referral and self-monitoring function is to support a continuum care across facilities and self-monitoring at home. We hypothesized that different capacities of home-based record users were observed, required for the respective home-based record functions across various home-based record types. Regarding data recording and storing functions, across various types of home-based records, for health workers, it's expected to function as data sources for clinical decisions and assist early detection of mild status of health, and it's more reliable data rather than the recall-based for health statistics. Sometimes it's used for the performance, the evidences, and also the save the unnecessary care. That's why it could be the save for the cost. For mothers, it's expected to function as a personal data at home. So some countries use it as an eligibility documents for subsidized services, for example, the conditional cash transfer. But anyway, this function is a basic expectation for all types of home-based records. When we see home-based record is functioning as the data recording and the storing function, caregivers need to take it for the service settings, and sometimes family members help it, and the health personnel needs to fill in the record from the health facility data as well after they provide the services. So to obtain this function, we may request capacities of the health workers in conducting clinical tasks and the record data on home-based records. For mothers, we expect their capacities in retain the home-based recourse and take to the health facilities. Regarding behavior change and communication functions across various types of the home-based recourse, for health workers, it's education material, communication assist, and the facilitation guides. For mothers, knowledge sources, guides on upcoming care, and the triggers for families to support mother and the child in their families. In the field, to make this happen, the mothers, sometimes the family members read it and act based on that. And the health personnel guides based on the information and records on the home-based recourse. So for these functions, the women and caregivers are needed to be able to read and understand the contents of home-based recourse and to take necessary actions, which are not necessarily required for the level 1 function for the recording and the storing functions. For the health workers, we must request their capacities to use home-based recourse for health education, not just pass the handbooks on the hand of the mother and the child. Regarding referral and health monitoring function, for health workers, it promotes the care continuity across facilities. That's why we expect empowerment for the community health workers to link between the facilities and the community. Mothers, it's a self-monitoring aids and a self-referral aids. And then sometimes they expect as a promotes the attachment through self-monitoring for child development at home. So for the referral tool, we expect from the community health workers and the health practitioners in the hospitals, both in public and private, they are referred and recorded. And for the self-monitoring, if mothers are asked to fill in by themselves, and then the families are checking by using the record at home. And then sometimes it will be kept beyond the age for their health archives. This function is very important for mother and child health services because pregnant women and mothers are usually receive health services and care at different facilities at different stages. So for the health personnel are required for the remind users to take home-based recourse to different levels of facilities, and they recognize home-based recourse as their referral forms, not others. And for the mothers and caregivers, take home-based recourse to the every health facilities at referral, and also they are asked to fill in or to monitor it. Therefore, this function is higher capacities for both users are requested. When we put functions from level 1 to 3 in the same diagram, respective capacities for both users are increasing, which is presented in this diagram. Hypothetically, progression of users' capacity that enables home-based recourse to function as designed is presented here. To enable expected functions real, relationship between levels of expected functions and the levels of the required capacities need to be recognized. Gaps may have caused inadequate use. To fill in the gaps, this diagram may assist health policymakers in identifying the discrepancy between the function a health system demands and the functions that can be realized within the capacities of current users. When a record designed for higher level functions is employed for users of lower capacities, policymakers need to take from two options. One is downgrade expected functions, for example, from level 2 to level 1, or add supplementary elements to increase capacity of users in two directions. First, designing records for greater user friendliness. If health workers are reluctant to record clinical data on home-based records, invest on easier format for transcription from facility data for home-based records. If losing and not receiving home-based records are concerns, invest on increasing perceived values by clients by adding figures or illustrations for more understandable and attractive to illiterate or less literate mothers. Minimizing the use of medical terms and avoiding wordiness in the text is always the good strategy. The next is the supportive interventions to be added for increasing users' capacities. Design and implement health services with home-based records as a package will be the start. And orientation, refreshing training for health workers are essential for all levels of home-based records functions. When do the trainings, try to design carefully to fill the gaps between current capacities and required capacities. Pre-service education could be an option besides in-service trainings. Health professional associations and NGOs are potential to have a roles to influence health workers in both public and private health facilities. For example, by awarding health workers for quality care using home-based records. Guides and manuals and supportive supervision will be essential to strengthen the capacity of them. Home-based records have been expected to function in many ways across various types of home-based records for both users. Capacities required for home-based record users differ according to the levels of home-based record functions. The more functions an home-based record is equipped with, the higher capacities home-based record users would be required to have. When designing an home-based record, capacities of both types of home-based record users must be assessed and considered. An optimal type of function or type and function of home-based record should be strategically selected based not only on health systems demands, but also on home-based record users' capacities. Thank you for your kind attention.
Thank you very much, Keiko. And that was a wonderful summary. And I really like that framework between the different levels, let's say, to identify what the issues could be and how that could be addressed either by downscaling or increasing capacity, etc. And so we'll now go to the second part of this session. But I would like to encourage people to use the chat. We have a whole chat page. I see there has been one comment so far, but really now that we go into country lessons and feedback from what is really happening on the ground, it might be nice also for people to reflect their own experiences in the chat. And so our first speaker is going to be Dr. Tabu from the Ministry of Health from Kenya. And Dr. Tabu has been providing overall leadership for immunization activities in the country, including in translating national policies into actionable plans and coordinating the national annual planning process for immunization. And we will hear from him their experiences with home-based records in Kenya. Over to you.
Thank you so much for this great opportunity to present to you the findings within the country of missed opportunities for vaccination assessment. I shall kindly request that you allow me to share my video so that I can be able to give the presentation. Thank you. Thank you. So, ladies and gentlemen, I am here to share our country experiences and presentation on the home-based record ownership and use of the recording fields. And this is the case of the Kenyan missed opportunities for vaccination assessment that we did carry out in the country in the year 2016. Just by way of background, just to share, this is going to be the outline of my presentation. I will take you through the history of the home-based records in Kenya. And under here, I'll also give you a brief context in which the country operates. From there, then I will take you through the missed opportunities for vaccination assessment that we did, really what the scope is, the strategy, and all that. And then finally, I'll be able to take you into the specific aspects of the home-based records. Kenya is an East African country located in Africa, borders the Indian Ocean. It is administratively governed under 47 counties, which ordinarily in other countries you'd call districts. Implementation of health within the country follows a devolved function in that the national level is responsible for policy formulation, technical support, and capacity building, of which I lead. And the county level, the districts in other aspects are responsible for implementation of the health services. We do offer immunization services as a country free of charge through a network of more than 10,000 health facilities, all of them public, private, NGO-based, and even private, offering free government vaccines. We overall give 13 antigens, so to speak. The home-based records, ladies and gentlemen, have been in existence in decades for us as a country. They've been previously existed as fragmented pieces related to antenatal, delivery, postnatal care, family planning, etc. And so the experience of a visit by our health managers to Japan in the year 2000 is what spurred the current concept of the integrated home-based records that we do have in the country as it is now. The home-based records, the biggest use as shared by the previous presenter, mirrors what we have in the country in that it complements the health facility records for care of the pregnant women, the mothers and children, really through their life course from the time they conceive to delivery up to the when the child is about 5 years old. So the key aspects, just like shared by the previous presenter, is that it shares health information, gives reminders to mothers of key dates, gives information about danger signs and aspects of us being able to implement high impact interventions to turn around the mother's health, monitoring, self-monitoring at home, and they give us standardized, sort of like prioritized quality of care across board. So in the year 2000, we had this visit. Throughout that period from 2000 and 2007, we had several pilots going on throughout the country, but the need for earlier diagnosis and treatment of HIV led to a piloting that was much more to scale in the regions with the highest burden in around 2007, and resulted in an endorsement of the integrated home-based records, that is the MCH, Maternal Child Health Booklet in Kenya in the year 2010. This has since been incorporated in the national guidelines to ensure sustainability, and it's also provided free of charge to the mothers, even when they do lose this book. So how about the missed opportunities for vaccination? A missed opportunity for vaccination is any contact with health services by a child or adult who is eligible for vaccination, but which does not result in the person receiving all the vaccine doses that are due to them and for which they are eligible. So this is what constitutes the missed opportunities for vaccination. It is we took upon it as a country, as a programmatic assessment at the national level that we are highly interested in, largely because of our stagnating immunization coverage and our need to be able to prioritize interventions to improve coverage and equity really as a country. So what did we do? We then went out to plan and prepare for the missed opportunities for vaccination strategy consciously, planning for the assessment, planning for the fieldwork, bringing all the stakeholders on board, determining the best methodology in which to conduct the fieldwork, which led to the conducting of the fieldwork. I must share at this point in time that it was a mixed methodology kind of assessment where we employed both qualitative and quantitative methods. We then did analyze the data, identifying key themes around which we would be able to intervene, brainstormed at all levels, and finally ended up with a debrief with the Ministry of Health and partners. The result of these missed opportunities for vaccination strategy led to a number of interventions recommended and which we are implementing to date, and which form part of the national immunization strategy that we are going through to that. So in summary, we identified issues around three common areas, around the caregivers, the health systems, and the health workers. The main health system common reasons for missed opportunities for vaccination were really limited hours of operation of health facilities, shortage and stockouts of vaccines, lack of integration of the programs, amongst others. As concerns the health workers, we had low home-based record retention, or not bringing the home-based record to the clinic as being one of the biggest contributor to missed opportunities of vaccination. Others were lack of awareness of the schedule and vaccine hesitancy among the caregivers. Among the health workers, we had again a big issue relating to their home-based records. This is failure to screen the vaccination status as the caregivers brought the children for vaccination or as they transitioned through the health facility for other services. Other reasons were false contraindications and concerns about recatch-up of the schedules for vaccination. So the missed opportunities for vaccination assessment, ladies and gentlemen, was carried out in November 2016, and it utilized a mixed methodology. It involved 10 counties, which are akin to districts that you may have elsewhere. 10 counties were purposely selected to represent the various geographical regions. And in these 10 counties, we selected 4 health facilities per county. Again, this was purposive, but taking into account the size of the health facility in as far as it being a referral facility or a community level facility, the location of this facility in as far as it being an urban or rural facility, the ownership in as far as that being a public or private or NGO based, and the routine immunization performance utilizing pentavalent 3 as a proxy indicator. So field teams within these areas approached caregivers with exit interviews. These were caregivers of children aged less than 24 months. Overall, we had more than about 600 interviews conducted among caregivers and using standard questionnaires. And we also had health workers interviewed, about 300 of them, for qualitative and quantitative interviews. We had the mother-child booklet, which contains the child's comprehensive vaccination history in Kenya and other temporary documents that were available at the time, reviewed for the history of vaccination of the child and just determining the reasons for the visit to the health facility by the children. So ladies and gentlemen, in the next, from that assessment, the biggest reasons for the visit for the children, for the caregivers is as shown below. The children that did miss vaccination, those that were accompanying caregiver 100%. Those that were due for another medical consultation and that were having a healthy child visit were 86%. But those that were coming, among those that were coming for vaccination visit, we had 20%, ladies and gentlemen. So I'll go, ladies and gentlemen, to the home-based records findings from the missed opportunities for vaccination assessment. Overall, 677 children were identified with a valid date of birth and who were less than 24 months of age. Of these, more than 76% had a home-based record available during the health facility visit at that particular time. 20% reported owning a home-based record, that is the mother-child booklet, but they did not have the document at that particular time of the exit interview. Now, among those without a home-based record, about a third of them, that's about 41, stated that they did not know the importance of bringing the document with them to every health facility visit, ladies and gentlemen. This forms a key area of intervention as a program for us as a country. There are quite a number, again, who indicated that they did not come for immunization, about a third again, and hence the reason for them not carrying the home-based record. 4% of not did not have the home-based record at all, and they reported it as either having had it lost or having never been given, which again is critical. Ladies and gentlemen, in as far as the ownership prevalence is concerned, we had greater ownership of the home-based records among children less than 6 months, that is at about 81%, compared to those children that were 12 to 23 months at 72%. We also had lower ownership prevalence for respondents with no formal education, that at 54%, compared to those who had higher education, that is those who had completed at least secondary or higher schooling, at 82 to 84%. We also had greater ownership prevalence among caregivers whose decisions about vaccination were a shared responsibility of the mother and the father at 83%, compared to those where the decisions were singular, either the father 50% or the mother at 70%. 2/3 of the caregivers, although it is not reflected here, identified the home-based records as a tool for determining the due dates of vaccination, but had significantly others, about 10%, identifying the home-based records as a tool for monitoring care and growth monitoring. 5% identified it as a tool for seeking treatment, and a significant 4% identified it as a tool for indicating the return date due for vaccination. However, more than 50%, just to report, more than 50% of those that reported having lost the home-based records, that is 6% in total, had no challenges replacing it, given that it is free within our contexts. As relates to the healthcare worker knowledge, attitudes, and practices relating to the home-based records, around 2/3 of the caregivers noted that they were asked by the healthcare workers to see the home-based records during the health facility visit, ladies and gentlemen. And across the 516 home-based records that were reviewed for that time during the study, the recording areas were most commonly identified for the child's demographic information, that is 80%, vaccination history 82%, and more than 90% of these were actually marked with the information. But the recording areas were less frequently available for child eye and vision problems. Like I shared, ladies and gentlemen, we have an integrated home-based records. They were less frequently available for growth monitoring at 74% and vitamin A at 76%. 70% of the health workers also felt that vaccination should be assessed in the home-based records during the child wellness or routine visits, during consultation for any illness, and when accompanying a caregiver. So they know that they need to have this done. But however, when the health workers themselves were asked who should evaluate the children's status, 33% of them said the nurse responsible for immunization should be the one to evaluate the vaccination status. Now, this is potentially one of the biggest sources of missed opportunities for vaccination for us as a country. So in conclusion, ladies and gentlemen, we note that the home-based records are critical to reducing missed opportunities for vaccination for us as a country, and the importance must be emphasized, and the document must be requested by all health workers at every health encounter. That we must not only ensure that all children receive a home-based record and counsel caregivers of its importance, but they must also ensure that sections of the record are legibly completed to ensure continuity of care and linkage to the health facilities. And lastly, that programs need to be encouraged within us as a country to periodically review and critically assess the home-based records to determine the document's design, the content areas, the functionality, and also the optimal use to end users, noting again the level of illiteracy within our countries. And of course, again, this linking to what has been said before, that the home-based record serves as a communication, education, a data, information sharing and self-monitoring tool for the caregivers within the country. Thank you, ladies and gentlemen.
Thank you very much, Dr. Tabu. And I think you're really highlighting nicely sort of the attitudes from both the healthcare worker side on how to use the home-based records, as well as from the caregiver side, and also some of the systems issues, etc. So I'm sure that during the discussion, we will go into more in-depth questions around these kind of issues. And so I would now like to introduce Dr. Suparmi, who is interested in maternal child health research, and including in monitoring of the implementation of home-based records in Indonesia. And she also contributed to the development of the Public Health Development Index in 2010. So Dr. Suparmi, welcome to talk a little bit about how home-based records are being implemented in Indonesia.
Okay, thank you, Dr. Anshu. Allow me to share my presentation. Okay, in this session, I would like to share the implementation of home-based record for the maternal and child handbook. We will also assess the subnational inequality implementation. Let me move to the Indonesian outlook. Currently, Indonesia is a rapid growing middle-income country and fourth largest population in the world. And Indonesia also have a more than cities spread in more than 17,000 islands. Indonesia also faces a challenge health system with decentralization of government, and currently we have 540 districts and 34 provinces. Moving to health indicators, Indonesia faces high rates of maternal mortality, high prevalence of child stunting, and also have a step rise on prevalence of NCDs. Let me turn to the implementation of MCS handbook. The MCS handbook was initiated in 2004, and it's in pilot project in Salatiga district of Java. And the in the piloted project, it continues to be a nationwide implementation in 2004, and the handbook is still continued to be implemented in Indonesia with revision every 5 years. And the MCH handbook in Indonesia is given to the mothers during the health checkup in health facility or in integrated health posts. And the objective of the MCH handbook is a guide for mother and children guide, and also for the documentation of health status and their history. And also this MCH handbook is used for the standard of the being used for the health providers. The MCH handbook has been implemented as integrated home-based record from pregnancy to children up to 6 years, and being used from pregnancy, breast preparedness, and for referral use. And the latest revision, we also include dental care for the children. And the benefit of the ownership of MCH handbook has been documented, and the ownership of MCH handbook is correlated to the higher likelihood to utilize of antenatal care, institutional delivery, postpartum care, newborn care, vitamin A supplementation, and our national survey also captured that mothers who have maternal and child handbook has lower odds to give birth low birth weight children. Now we continue to the specific evaluation or measurement on the utilization of MCH handbook. Our national survey captured that MCH handbook ownership among pregnant mother and under 5 children. Among pregnant mothers, our national survey showed that the MCH handbook increasing from 29% in 2010 increased to 66% in 2018. And among the national survey showed in 2018, 25% of pregnant women still do not have MCH handbook. Continuing to the MCH handbook ownership among under 5 children, there was an increase of coverage of MCH handbook. There were 50% of the children have a MCH handbook in 2018. And the following these, however, still 16% of the children cannot show the book during the survey. This might be happen because the book was kept by the health staff, and then this is because of the concern of the family might lose the book, so it decrease the probability of the family to read and to learn the MCH information provided within the book. In this presentation, we show that Indonesia also facing challenge in the implementation of home-based records. We can see here the disparities between provinces. Provinces in the extremity western and eastern area tend to have lower coverage of MCH handbook. We can see here provinces like West Papua, Papua and Maluku, Aceh, North Sumatra, and Riau have a lower coverage of MCH handbook. Indonesia also facing district disparity within and between provinces. We can see here in North Sumatra province and Papua province with a wider disparity compared to other provinces. While we can see in Jakarta provinces, it's smaller inequality between districts. We also identify factors associated with MCH handbook ownership in Indonesia. We can see we break down the zone in red zone, yellow zone, and green zone. We can see here the identifying factors in green zone is more likely because of wealth index, while in red zone and yellow zone is because of place of residence. While other factors like parity, age of children, and mother's education is impact on the associated MCH handbook ownership in red, yellow, or green zone. Indonesia also facing a challenge on the utilization of MCH handbook. We can see the utilization based on the fulfillment of MCH handbook. We can see here that the fulfillment of MCH handbook is ranging from the 44% in newborn and very high prevalence of the utilization on immunization history and also history. Well, if we composite all the record based on the pregnancy into child development, it's complete 6 component on 20% will complete the MCH handbook. We also identify factors associated with MCH handbook utilization. We can see here that wet quintile again associated to MCH handbook utilization in green zone, while you can see here that place of residence is do not affect the utilization of MCH handbook. We continue to the national and subnational regulation also plays important role to improve utilization and also ownership of MCH handbook. We can see in our Minister Health of Regulation in 2004, this continued to be a commitment of national-wide utilization of MCH handbook. And we also using the MCH handbook as a kind of ensure fulfillment of minimum service standard. And MCH handbook also being used for a verification instrument for national health insurance, for pregnancy care, delivery care, and postpartum care. And we also use MCH handbook as verification instrument for cash transfer among the poor. And local government also play an important role at subnational level to increase the use of MCH handbook. In summary, from this presentation, we conclude that still 25% of pregnant women in Indonesia do not have MCH handbook. That's why we should encourage the outreach activity, especially in rural area, and encourage local government to produce MCH handbook. And we still need a strong commitment of central and local government as well as all stakeholders to increase MCH handbook ownership and utilization and make sure the commitment is well implemented in the field. And to optimize utilization of MCH handbook, health providers should allow mothers to keep their books, so the information and also the recording of the book is being fully utilized by the mother. And again, monitoring of MCH handbook will help central and local officials to develop evidence-based action plan to improve MCH strategies. We also encourage other countries to put and monitor home-based record in the health system. Thank you, Anshu. I will give back the time to you. Looking forward to our discussion.
Thank you. So thank you very much, Dr. Suparni, and for indeed highlighting some of the implications that you have seen, some of the constraints that you have seen on the ground. So I'd just like to highlight the second poll that took place, looking at what kind of home-based records we have in the different countries. And if I just see what we have here, 11% are only a child vaccination card, 22% go beyond child vaccination, including growth monitoring. 22% have a complete child health booklet. For some, it's only a maternal vaccination card. For some, it is a combined booklet for mother and child health. And some have already moved to a digital home-based record. And I see that there are some questions also in the chat and about experiences around this, etc. So wonderful to see this. Please put in your comments in the chat so that we can really share experiences. And we will now go to the third session of this webinar, and that is to hear from Dr. Pearson and Dr. Aiga about global views. So first we will have Dr. Pearson from UNICEF, and she will talk a little bit about what they have learned. She provides strategic leadership, management support, and overall direction to UNICEF's Global Health Program, and is based in New York. Luwe, over to you.
Thank you. Thank you, Anshu and the host. Can I be allowed to share my screen? Okay. I hope you can see my screen, Anshu.
Yes.
Okay. Thank you. This is Lu Wei from UNICEF New York. I want to talk about mainly on the use and use home-based record to support real-time information. And it's really useful to hear the overall framing and the country examples. And I want to spend the next few minutes to talk about where UNICEF sees the situation on the ground and what we can help. Focusing on the linkages of MNCH card with real-time information and the qualitative as well as quantitative information, the importance of a balance, and the importance of moving from recording to actions. Since COVID-19, UNICEF has monitored the coverage of essential services. If you remember, at early stage of the pandemic, there was several modeling exercise done, projecting that there could be additional 6,000 additional under 5 mortalities if essential health services would be severely interrupted. Several months into after the estimate came out, UNICEF was able to work with WHO and partners to look at the situation on the ground. So we looked at the Q2 2019 and the Q2 2020 data. So compared quarter on quarter of different years, we saw the impact on immunization using Penta 3 coverage as an example. The degree of reported interruptions varies significantly amongst countries. You have countries on the left-hand side in the dark red color: Peru, Pakistan, Bolivia, India, Bangladesh, etc. reported severe interruption of services, while in West Africa, there's even reported increase of routine services. So the spectrum is quite different. We thought the physical distancing policy, lockdown strategies, as well as the COVID-19 caseload may have caused the pattern, the difference among different countries. Peru has a much higher, for example, per million population COVID-19 caseload than Ethiopia and DRC. So this is just an interesting overview at the global level. For pneumonia management, we did not see any reported increase. Almost all countries reported reduction of pneumonia care seeking between 2019 and 20 Q2. So this is quite alarming that life-saving services are being affected. Many speakers before me have talked about the importance of nutrition data in the MNCH card. Again, an example from Nepal showing in 2020, which is in red color, the proportion of children 6 to 19 months admitted for treatment of severe acute malnutrition has been severely affected, and the recovery has not yet started. So all this means that home-based record to support the local health management information system can play an important role to monitor the interruption as well as recovery of essential services. Last year, I was in DRC. On a day, I visited a health center. So this social worker is doing birth registration. She has to write everything 4 times. So on this page, it's 4 records by the same one because they go to different places. One kept at the household level, one goes to the government at district level, one goes to the birth registration one stays at the health center, and she has to copy 4 times. So this is a great example just to show the importance of digitalization, as well as linkage of MNCH card with birth registration processes, linking health and the social welfare system together. In India, we are supporting an evaluation to look at how the MNCH card is used, very similar to what Kenya presented. We hope to bring the evidence to practice. This Ethiopia home-based record is linked with community health information system for both counseling and monitoring essential services. So the 3 key messages that I want to deliver today is we want every child, no matter where the child is, a girl, a boy, a child with disability or not, should have access to services as well as MNCH scorecard. The notion of equity and the children in disadvantaged position and the more vulnerable position needs additional help. And the card is not just for recording child survival related interventions, but more and more for growth and well-being, including mental health. And lastly, a MNCH card is a stronger, provides stronger opportunity to strengthen the health information system. Thank you, Anshu.
Thank you very much, Lu-Wei, and also for showing the link with COVID and why it could be useful currently. So then our final speaker for this session is going to be Iratsugu Aiga, and he is a professor at the School of Tropical Medicine and Global Health at the Nagasaki University, and has more than 30 years of experience working on global health, particularly on health system strengthening, but also in Africa, particularly in Africa, Asia, Europe, and the Americas, and has also been working with UN and other bilateral agencies. And so over to you, Aiga, to present on lessons learned from a global perspective from your side.
Okay, thanks, Anshu. Can I share my screen? Oops. Can you see my slide?
Not yet.
Not yet. Oh, oops. I hope you can see.
Yes.
Okay.
But we see the full screen. Yes, there we are.
Okay, thanks a lot once again, Anshu and the other colleagues. Really appreciate this opportunity to make short report or presentation about the challenges in implementing home-based record, particularly in maternal and child health. Currently, I'm working for the university, Nagasaki University, but before joining this university, I used to work with the Japan International Cooperation Agency, JICA, for 8 years. Out of 8 years, I spent 3 years implementing home-based record projects in Vietnam. So my presentations will be largely based on my beta experience in Vietnam. That should be more or less applicable to other countries, I guess. So it should be hopefully give you the kind of global picture on what's going on at the country level. My presentation is very short. Part 1, challenge on implementing home-based records. When I was in Vietnam, 2012 to 2015, we have conducted surveys on the prevalence of home-based record in 28 provinces out of 63 provinces. And it was found there are 23 home-based records which are implemented. Out of 23, 4 were home-based record only for pregnant women and mothers, like maternal handbook, antenatal care handbook. The 5 are home-based record only for children, like a child vaccination handbook or child vaccination card or growth chart and some others. 13 are home-based records for both pregnant women, mother, and children, like a MCH handbook, MCH record book, some other, so many. And the type 4, there is only one home-based record for all age group for both male and female. So in total, there are 23 home-based records. Then it was very surprising that all the 28 provinces were implementing 5 home-based records or even more. The most extreme cases, one province, Anzan province in southern Vietnam, they were implementing 11 home-based records. So needless to say, some health workers have to record the same data on several home-based records. There's a number of cases of mistranscriptions and waste of time. And it's a lot of confusion. They spend more time on recording rather than talking to a consultation with the patient. So this kind of field reality is not well known, although we know that HBR has been implemented, has been operationalized in more than 163 countries. That is great, but very little is known at what's going on in the country level, particularly sub-national level. In Vietnam, this is also very typical in other countries as well. The child vaccination handbook, this is implemented by National Institute of Health and Epidemiology, what we call NIHE. And growth monitoring chart is the implementation of growth monitoring chart is the responsibility of National Institute of Nutrition, is a part of MOH. And the maternal and child health department is responsible for maternal child health handbook. And medical service department is responsible for implementation of the healthcare handbook. Each department or national institute have different home-based records. It's totally, they are developing, constructing a very high and a kind of silo. And what is very interesting was that UNICEF and Gavi have been supporting NIHE for the implementation of the child vaccination handbook, mainly printing and distribution. While WHO is supporting printing and distribution of growth monitoring chart, JICA has been supporting printing and distribution and a bit of implementation support on maternal and child health handbook. And some local NGO, one local NGO was supporting the province-specific home-based record. It's totally fragmented support. So there are 2 types of fragmentation: fragmented home-based record, fragmented support to the implementation of home-based record. This is the reality in Vietnam, but even some other countries. Last year I visited Mozambique. They have more similar situations. And then visited Madagascar. They have similar situation as well. So kind of key message or kind of solutions or response we have to make is, first of all, WHO, UNICEF, JICA, CDC, Plan International, Gavi, all Save the Children, all those development agency NGOs should work together at country level as a one team, not to confuse ministry, technical department of Ministry of Health, not to fragment the support. And by doing so, maybe home-based record will be recognized as an integral part of health information systems. Home-based record is not just for the, it's not just a technical tool for maternal child health, but it should be also important technical tool or for health information system. That is why we are here, HSR 2020. Another kind of response we have to make is filling the research gap. What we need to know and what actually we know is a huge gap in terms of home-based record. There are two examples. One, a research question. We don't know which is more effective, integrated home-based record or standalone home-based record. Integrated home-based record like MCH handbook, which covered everything, the from pregnancy, delivery, child immunization, growth monitoring, or standalone home-based records, maybe home-based records only for pregnant women, mothers, only for child immunization, only for growth monitoring. We don't know which is more effective. We have only one randomized control trial in Indonesia. Currently, JICA is very much enthusiastic implementing, conducting the cluster randomized control trial in Angola also to compare these two types of home-based records. Second, research question number 2 is a cost analysis on home-based records. Policymakers need to be well informed that investment in home-based records ultimately increase effectiveness and efficiency of the MCH services. Unfortunately, there is no cost analysis on home-based records. That is why many Ministry of Health are a little bit hesitant to budget for the MCH home-based records. They always rely on external funds like development agencies or NGOs in terms of development, designing, printing, distribution. So to make Ministry of Health totally independent on the operation of the home-based record in the area of maternal and child health, maybe we should definitely conduct cost analysis studies. These are the two key messages from my side. Thanks a lot.
Thank you very much, Dr. Eigamp, and for also highlighting so clearly the fragmentation that is taking place, and really for the need for that kind of coordination, and also on the research questions, because as we said at the beginning, I think the guideline development group had also highlighted some issues that still needed to be addressed. So that brings us to the last part of the webinar, and that is the Q&A. And I think we've had some inputs into the question or into the chat. So please keep on putting some questions there as well for the panel members. I think we can sort of maybe kick off with one that is having everyone's attention in relation to COVID, and that is about digital health and how do we use digital health. Have there been any experiences around digitalizing these home-based records? And we saw in the poll that around, I think, 8% of countries have already started looking at a digital home-based record. And so maybe we can kick off with Dr. Suparmi. Dr. Suparmi, I think you have already had some experience with digitalizing the maternal child health handbook. And so maybe you could kick off the question and answer by reflecting on this particular issue around digital health. And either Dr. Suparmi has a problem with the sound or her mic is still on mute.
Thank you, Dr. Anshu. Indonesia is currently working on digitalize our MCH handbook, and this is a part of a project collaboration also with JICA in these years. And some digital record actually already set up by professional organization, and in the umbrella of JICA collaboration, we currently assess the digitalized of MCH handbook, and will integrate it into a single platform, and the single platform will be recommended by Ministry of Health to be used by mothers and also health professionals. So it will be a recommendation on this platform. Thank you. Thank you, Anshu.
Thank you. Thank you, Dr. Suparmi. And I was wondering whether Dr. Collins maybe would like to also say something if there are any experiences in Kenya.
Thank you so much. From the Kenyan perspective, we don't have solid experiences, but we have a growing interest in digital health interventions as it is now. And we're making strong considerations given that it's a dynamic field. We're making efforts to really look at interoperability and take a step at a time in terms of considerations of the systems. Currently, we're looking at starting with smart paper technology and then going up to full digitalization much later. Thank you.
Thank you. And because we are digitalizing the health information system very much at country level through the DHIS platform, have any of the countries thought of making a link between the DHIS platform and the home-based record? For any of the panel members, if you would like to speak, you can raise your virtual hand, and then the moderator or the moderator can sort of give you unmute you. But maybe I come back to Dr. Tabu. Have you thought of maybe making a link with the DHIS system now that you are starting to think through how to have a digital medical or a digital home-based record? Yes, please, Dr. Suparmi.
On the integration of the AI and the integration of MCH handbook. This is also we have been working on, because we have in the umbrella of the Ministry of Health decree that it should be one data in Indonesia. So the MCH handbook should be integrated in the one platform. So in Indonesia have a unit on data and also disseminate information. So all the indicators in the MCH handbook should be put in the platform under umbrella of the Ministry of Health. Thank you.
Thank you. Yes, thank you. And maybe I could ask Dr. Aiga whether he is aware of any other country that might have looked at how to integrate the home-based record with the DHIS platform.
Thank you, Anshu. I don't have a lot of knowledge on that, but what I know is the kind of trials made by or having been made by Palestine. Oh no, sorry, not Palestine. It should be Anrua, refugee camp. There is several trials for digitization of home-based records and maternal child health handbook in Palestine refugee camp, and it's been successful. But they have already digitized, but it's in a process of linking between the MCH digitized mobile phone-based home-based records to the clinical data and facilities. They are still in the process. I don't know what's going on, whether it's successfully implemented or not. still in a trial basis. Maybe Keiko knows. She has more than I have.
Keiko, would you like to come in?
I will try. Hi, can you hear me?
Yes, we can hear you. Please.
Thank you. I successfully jumped in. Actually, to my knowledge, it's still in a pilot phase, and maybe the UNRWA colleagues can help us afterwards. But anyway, the somehow the platform we need to have the digital one, and it should be the linked out for the individual mobiles applications form. But were there the application, the mobile, the devices available for the individuals or the within the families, and also how far it's downloadable, and after the downloaded, it's already functioning or used. Is it somehow gaps are observed in the previous report by UNRWA? So we need to trace, we need to watch how to make it more real. And also, in many countries, we observed many private sectors already developed application forms, and which is more fragmented than the paper-based, the home-based recourse, to be honest. So maybe the sustainability and the scaling up has been always the issue for the paper-based home-based records as well. And the digital devices also as just a tool. So whether based on the digital or the paper is not matter. So whether the home-based record data could be linked to the health information systems, which is available in the digital, could be the matter. So maybe how much home-based record as devices for making the individual's records available at home or available for the client's hands is the matter of the health systems. After that, maybe we can solve more solutions. But in this context, under COVID, we realize another issues. So who has more connection to the digital, the environment, have more access to the information. But those who have not access to the digitals have maybe they remained. So we need to think about another gaps that we understand that digital devices can solve many things, especially for these limited conditions. But again, another gaps, we need to focus on that and try to find solutions together. So we hope the discussion on home-based recourse continues. Whether it's not matter the paper or digital. Thank you.
Thank you, Keiko. And I think you're highlighting something about the digital divide. And of course, we want to make sure that digital records actually, or home-based records, sorry, actually will reduce inequities in the community. So that's a good point to make. So while we're waiting for some other questions in the chat, I will ask one question for all the different panel members to reflect on. And the question is, what has been your experience with the implementation of home-based records within your health system? And of course, you can reflect on your experiences in other systems as well. And if there were any challenges or obstacles, what have you done to address them? But before I ask the panel members, I see Annie would like to comment on the digital issue. And so Annie, I hope you can be unmuted.
Yes, thank you, Anshu. It was very interesting to see this interest in digital health, and I just wanted to say two things. One, we are going to commission a background paper to try and collect experiences of what's going on in digitization of home-based records. And as Keiko rightly said, we've heard of a lot of pilot experiences. Maybe one or two places have talked about scaling up, but it would be interesting to learn more about the potential, what's been done, and lessons learned in order to move forward. A second point I wanted to make relates to a comment that Charlene Goliath had written in the chat box. And we are working with colleagues in health system, and while they are looking at defining what are core components for different health areas, as part of DHIS and as part of facility registers, we are also trying to map and understand what is being recorded in digital records and see if what is recorded in home-based records, and trying to match what is important, what is recorded in home-based records, and how does that map to facility records. We heard a really interesting presentation from our colleagues in JSI the other day. And somehow one of the things we're not understanding is who is the information on the record for. Many times it's of course for the mother or the parent or the caregiver for their use. But does that mean that that's the same information that's interesting or needed by the health facility and the health worker? And as long as they don't speak to each other, we run the risk of either overloading it and trying to put information that interests everybody, and then of course the record suffers from being too big, or two, we only meet the needs of one of the sides and then the other side doesn't find it useful. So these are things we're also trying to explore further.
Thank you, Annie. And so maybe I'll just do a tour de table around this question around experience with implementation of home-based records. And there are two questions in the chat that you could maybe reflect on as well. One is whether any of these home-based records have included something around maternal and perinatal mental health. And secondly, about this issue, and I think it was mentioned in one of the presentations around the fact that people could use different health facilities. And so what have been the experiences with that? So maybe I first start with Dr. Collins to reflect on some of these experiences.
Thank you so much. I'll start with the last question in terms of country experiences in the implementation of home-based records. The home-based records implementation in the country took a bit of a long time to implement. It was slow in terms of getting accepted, and as usual, people initially are resistant to change. But the Ministry of Health did adopt it as a policy issue, and because of the HIV programming at the time that had significant funding to push its support, it was then widely accepted and it was taken up. Now the availability of home-based records really for us is beyond 90%. But this does not mean it has not faced challenges. We have had opportunities to regularly update the home-based records. However, we are faced with a few challenges, that of frequent stockouts of the home-based records in terms of challenges of financing, just being able to print them. The inadequate use of these home-based records, often the health workers take shortcuts in terms of filling them or utilizing them for the intended purposes, or just backpassing the responsibility to look at various sections. And sometimes the messages utilize a lot of graphics in our home-based records to try and make things easier, but in trying to make things easier for different cultural contexts, it actually becomes complicated because it's difficult to get a one message fits all for all the cultures within the country. And lastly, given that it looks at the maternal components, the antenatal components, the child health components, and even immunization, it becomes sometimes a challenge to coordinate between health programs. In terms of the relationship with the mental health, we do not have at this point in time have the perinatal mental health issues addressed in our home-based records. To me, this is good information that we'll be able to pick on forward and recommend for introduction. For most of it focuses on within the perinatal period, focuses on the child, and even up to the child, the time the child is 5 years. So we do not have a lot of experience with this. Thank you so much.
Thank you, Collins. And Dr. Hiro, maybe you could reflect, because Collins has just highlighted the issue of fragmentation. You showed in your slide on Vietnam the kind of donor fragmentation we have had in supporting the home-based records, and really the need at country level to come together. Could you say something more about how we could take that forward?
Okay, thanks, Anshu. My experience in Vietnam was, as I mentioned already in my presentation, it's really hard for the both development agency and also the technical department, Ministry of Health. But after the survey, I requested major development agencies, including NGOs like World Visions, to sit down and discuss. And it was really a great discussion. Then they are almost in agreement. So they try, all the development agencies, particularly UNICEF, WHO, JICA, World Visions, Vietnam, those organizations try to approach the Ministry of Health as one team, but unfortunately, the interdepartmental coordinations, collaborations, or harmonization within the Ministry of Health was really hard. That is a bitter experience in Vietnam I had. But in Zambia, I visited Zambia just 1 week, but quickly they are, I mean, each department of Ministry of Health, like the Child Health Department, the Preventive Services Department, they work together. They are already in a good shape in terms of collaboration, interdepartmental collaboration. But unfortunately, development agencies are not well coordinated. So what I want to say is that situations in terms of challenges in the coordination between the technical department of Ministry of Health and the development agencies is quite different, one country to the others. I just want to add on the top of that, another challenge I haven't mentioned, but I want to tell you now is that once we organize, let's say, the technical working group for development and designing home-based records, particularly the integrated home-based record for MCH, then each department or academia or agency started saying so many things. Okay, please include this, please include that, and finally, so we have end up having so many items, recording items. It will be very thick document. No, this is not, we are not developing encyclopedia, we are developing home-based records, handbook. So we have to minimize the number of pages, number of recording items, number of education materials, and so on. So we have to set up the kind of criteria for somehow limiting the recording item contents of the home-based record. Otherwise, if it's so technically sophisticated, mother will not understand what is there. They will not think it's very useful. Then it's very heavy. And then finally, it will end up not being used. That is also another experience I want to share with you. Thanks a lot.
Thank you very much. Maybe I can go to Dr. Suparni to comment on experiences in Indonesia around this.
Yes, I would like to highlight some questions asking on integration of maternal mental health. Actually, we have added this section in our last revision in MCH handbook in 2020 and have been disseminated in this pandemic era. But however, it's not as extensive as in the Antwerp. It's not the creation of anxiety and depression, but we only have a kind of information, but not as a reporting or as a report. And for the implementation of MCH handbook into our system, actually MCH handbook already put into our system. And we also have practically monitor the implementation through our household survey. And monitoring of MCH handbook is actually important at national as well as subnational level. It will help central, provincial, and local officials to develop evidence-based action plan designed to improve maternal and child health utilization. However, in Indonesia, as at this stage, we have some challenges faced. For instance, the implementation in decentralization at the district level, this challenge require local government commitment to the implementation of MCH handbook in all districts in Indonesia. And Indonesia also put a unique challenge on geographical variation. So, although central government have procured and distribute more than 5 million MCH handbook to local government, however, geographical barriers led to delay of MCH handbook distribution, and this might face inequality between provinces. Thus, we encourage local government to have their own procurement so they can meet the barriers between province and district. Thank you, Anshu.
Thank you. And I think Keiko, you wanted to come in with some additional comments.
Yeah, thank you, Anshu. And then the comments from it was Pami and Colin, Tabu, and Hiro. Yeah, the fragmentation of the home-based recourse were concerned, but the some integration efforts were we observed. So at the time, always the ownership of the country is very much important to tell to the outsiders, for example, the partners to integrate work to you. For example, the Afghanistan, Indonesia, Kenya. So those countries had a good, the strong voices for other countries, not to the work separately, fragmentary, but work together for us. So that's kind of the message is very much important to make the fragmentation into more harmonized way. But still, the now the fragmentation or some challenges continue. So at the time, we may also need some monitoring information and the data for which how much it's the home-based record is used. Like Indonesia today, so based on the national the household survey until the subnational level. So you presented some challenges, but based on the challenges presented, we will have some actions forward. And the Tabu's presentation was about the samples, but it's very much practically collected, both for the qualitative and the quantitative, and to reduce the missed opportunity. So it means the services that could be designed more attached with the home-based records, and the home-based record data could be used for more effectively to work it. But still, not many countries has like that. And the data tells us the challenges. So we need to have more data, and we need to have more understanding of the researchers to invest on their focuses and interest on the home-based records. Thank you.
Thank you very much, Keiko. Lue wants to come in also with some experiences. Lue, over to you.
Thank you, Anshu. Home-based record was created many decades ago, and it has served its great purpose in Japan and many countries nearby. In the coming years, where digitalization will take over the health management information system and DHS, we need to think ahead how to adopt the home-based record to fit into the evolution so that we are not left behind. I would also welcome ideas from Japan, because you are the almost, I could say, the birth ground of the MNCH booklet. You always tell the example, Keiko, that how your prime minister always shows his own MNCH booklet. What is the plan of Japan in the future? Are you going to keep it as a physical copy, or will you go digital? I would welcome some reflections from Japan. Thank you.
Thank you, Lue, for keeping the conversation going on this issue. Keiko, do you have any thoughts on that?
Thank you, Lue. And then in Afghanistan, UNICEF and the JICA is very much well coordinated working to support the Afghanistan MOH and with the initiation of the leadership by the WHO. So at the time, the beginning, so they are not well be in a good team, to be honest. But in the middle, they become the good team. I means not only the maternal child health section, but also HMIS. So to be linked with the facility data, to be precisely copied under the very much limited the health workforce and a very much hardship in the security, but they try to design very much minimum and effective the tool for them. And they are now using it and identify it as a good media for the promoting the prevention of the infection for the COVID and for the more guides for the mothers to keep the safety breastfeeding. So I think it's the good chance. It was very honor for have such countries to make the home-based record as a set for the health systems. And I forgot that the one question from the audiences. Are there any the home-based records who has the postnatal the mental issues covered? So I do say some countries like Japan do not have the concrete the scale for the monitoring for the maternity blue, but there is just blank form and a space for mothers. Please put your feelings or some worries if you have before you come to the regular checkup. So this is a very small notes, but within the space, the filled by the text or the just with by the blank form, the health personals will take some understand to take some messages from pregnant women, the postnatal mothers, who they are okay, they are happy or not. So still the home-based record could be more used for the other issues if the maternal and child health agenda and the focus of the issues are shifted. So that's my understanding of the opportunity for home-based record, which could be used for more than 70 years in Japan. Thank you.
Thank you, Keiko. And we know that Japan is very much advanced in digital health, etc. Is there a direction also for the home-based record to digitalize it, or not yet?
I think I could say it's not yet. It's the private application is already the way we could take, but it's not yet the linked with the health information system. But there is some plan and some discussions, and then it takes time. There's some meaningful discussions we did. For example, the privacy concern is very much the big one, and how to make sure that all data is very secured and to share with the individuals. So that's the big, after the big discussions, it's going on the step by step, I guess. Thank you.
Thank you. Yes, I think the data privacy issue is an important issue to be able to address first. So there's one question that we have from Divya about local calendars and how local calendars have been integrated into the home-based record in order for, let's say, the caregiver to have a better sense of when the child was born, etc. Are there any panel members who have experience with this in their home-based records on how maybe, let's say, the harvest seasons have been used, or the summer, winter, autumn, etc. have been used, or political events have been used, etc., to identify the date of birth and things like that. So if I see a hand up, I will be able to give you the floor, but it's really about local approaches, cultural approaches to make it culturally adapted to the local situation, and whether there are any experiences with that. Maybe I can just ask Dr. Collins, do you have any experience in Kenya about how to adapt it really to the local situation?
Thank you, Anshu. We do not quite have that experience. Remember, we have very different and varied cultural contexts. However, we do not have the extremes of winter, summer, or what we do have much more is occasional political events, which are big milestones. But otherwise, I do not have any particular experience I can think about locally.
Okay, thank you, thank you. Dr. Suparni, any experiences you have, anything that you have incorporated into your home-based records to adapt it to the local situation?
Yes, thank you, Anshu. Actually, in Indonesia, we have a decentralization era. So district level is allowed to modify the MCHN book. However, there is still a main information it should be kept, but they can be adapted to their local policy, so they can add more information to meet their needs in local government. As well as in some district, they change their cover to their mayors and or to their specific ethnics in Papua. It's kind of like that. So it's been a very extensive experience in Indonesia into local implementation. Thank you.
Thank you, and I think that's a very important point when you look at cost effectiveness, let's say, at how much adaptation can you make in different provinces or in different states in order to have maybe more ownership from the population to use it, while at the same time, of course, then you need to have different modules and you have to reprint everything in a different way, and so that has costs as well. So that's an important issue to raise. Let me see whether we have addressed.
Yeah.
Yes.
Could I say? Yeah.
Yes.
It's just adding to Dr. Suparmi's comment, the standard contents and optional contents. So so it is a very wise way to make a balance between the standardized, the essential items that is provided by MOH, and also adaptation by the local peoples. So that to make a balance is the very good strategies which we take in Japan as well, in China as well, I guess, and India. So we need to make a balance between the local and the standardized one. Thank you.
Thank you. So then there's maybe something else that we could maybe just for the last few minutes that we still have, just think about. And I think very much in relation to Keiko's presentation, but what are potential new home-based record functions that we could think about for the future that we think might be important? And so maybe people could just reflect on that. I think Keiko highlighted 3 levels of functions. One was around data, one was around sort of getting involvement of the caregivers, etc. And the third one was really around how to have this continuum of care between different services and referral and self-monitoring. But do people feel that maybe we could still have some additional functions that could be added to the home-based record, keeping in mind, as Dr. Hiro said, that it needs to be limited. We cannot make it a full encyclopedia, but maybe just for the last few minutes, a few reflections on that from the different panel members.
Anshu, just a comment from Collins here on
Yes.
what you just concluded in terms of adaptation. I would just like to urge caution. And like I did talk about the political milestones in my country now, I'd just like to share that we have standardized most of the home-based records, the mother-child booklet, so that no one is allowed to change the inside. But we've left some aspects, for instance, where people, private entities or subnational entities could brand. But what I saw, and just talking about the political context, is I'll give an example in one region where the regional governor branded the home-based records, the mother-child booklets, with the photos, with his photo and that of his administration. But then conceivably within a very short time, the governor does not appeal politically to all the people he governs. So you have people then who do not want to carry a booklet that has his image there or his branding there. So now then, even by way of staying very technical, now you find that you start hurting the program, the good intentions of the program itself, because we have allowed the adaptation to go beyond what then may be allowable. So I would urge a lot of caution in the adaptation. I would urge a lot of caution in what we would consider a standard and what we would allow to go on the curve and all that, because some of those then would push away the very health-seeking behavior that we're trying to promote. Thank you.
Thanks, Collins. That's a very good comment, I think, to keep in mind. Any other comments from other panel members on the second question about any additional functions? Do you feel
Anshu,
that...
I'm happy to come in to contribute one more idea.
Yes.
Is that okay?
Yeah, please.
I wonder if we can think ahead to link with the MNCH booklet with the UHC and the PHC agenda. What it means is we need to think about the linkage with the unique ID number of the national system, and maybe income and the poverty status of certain family to allow them to access free care or certain health insurance premium. And that's just not as a digital expert, but listening to countries, I feel this could be coming from other sectors. Everybody's talking about unique ID and the international registration system. Of course, linked to the protection issue of security, cyber security. I also feel there to trigger actions, the MNCH booklet could be linked to a reminder system. If a woman is missing the third ANC visit, or if a woman is near term to give birth, perhaps there could be a reminder. So the same as if a child is missing immunization, so the caretaker could receive, oh, your child should have come yesterday, something like that. I think their MNCH booklet is very rich, and if we are innovative and take it forward, it can have a great contribution to the future of health systems. Thank you.
Thank you, Liu Wei. And the issue of the unique ID number, of course, also links it to the whole issue of the district health information systems, because if we have the same unique ID number, then we can see how these kind of things can be linked up. And the triggering of visits, etc. There are some experiences with that also, again, through digital technology, with sending SMS messages 2 weeks in advance or 1 week in advance before someone is supposed to come for a particular appointment. And so indeed, if that could be all, you know, the ceiling of the digital technology, you know, can be broken, I suppose. And so we can make these kind of things workable. But then at the same time, I think we need to also keep in mind that there are still parts of the population who don't have access to smartphones, and maybe there's a way to do this through an SMS system as well. So thank you. Are there other panel members who have an additional idea for how to strengthen or an additional function for the home-based record? I see no hands up, and yes, that hand disappeared very quickly.
Oh, hi, Anshu. No, this is
yes.
Laura. So
yes.
Thank you, everyone. And I come from the immunization department at WHO, and some areas that I think we're, the home-based record is so important. And I think that the main message is that we want to try and ensure that they're brought to every health contact. And it goes in line with this improved integration and system efficiency that we want to try and achieve in health facilities, whereby every health contact is used as an opportunity for that individual to receive a health intervention, not just immunization, but other health interventions. But one issue, and I'm sure people on the call will agree with me, that in many countries we have a big issue with denominators because we're very unsure of the population size. So in some countries, we have seen advancements whereby the home-based record is somewhat linked to civil registration. And I think that over time will be incredible if this could be promoted further, so that we can have a better understanding of what our target populations are that we're trying to reach. It'll help us get a better idea of our coverage goals and targets, and in time it'll make us more efficient in terms of how we supply and meet these targets. So I think that could be a great opportunity, and some countries have good experiences with this, and hopefully that can happen more as time goes on.
Yes, no, that's an important point, and I know indeed some countries have used even the paper-based home-based record to support civil registration for the newborns, and so indeed that's indeed one of the potential benefits that we should maybe indeed strengthen a bit more. So we have a few minutes left, and I see no other hands up. Dr. Hiro.
Thanks, Anshu. Just want to emphasize the importance of welcoming, inviting the HSS people, health system strengthened people, rather than vertical program like nutrition, maternal and child health, vaccination. That is also great, but we need to have somebody else coming from the horizontal axis. We have a good achievement, successful achievement, IDSR, integrated disease surveillance and response, or HMS or DHIS. Those are maybe help us avoid maintaining the program-specific information system. So maybe by learning from this success story, we will be able to maybe include all stakeholders within the Ministry of Health in successful manner. So we should learn from them. So we should even ask them to, or tell them to come in, because this is HSR. So we have a lot of many of the audience are the health system strength people. We should let them come in and discuss and stimulate the discussions. And finally, we need their help so that we will be able to more efficient and effective home-based records. Thanks.
Thank you. Thank you. So maybe just in that case, to wrap up this wonderful session that has been quite animating, I think, and participation also from people on the call. To say that in this session, we have been looking at the home-based records as an essential element of health services, and Dr. Hiro just highlighted again how important the link is with health systems as such, and also how it is important that we aim to further improve the implementation of the home-based records. We've seen that even though most countries have said that it's part of their policy to that mothers always bring their home-based record to the visit to the health facility, we've seen that implementation has not always been 100%, and also even that the awareness amongst healthcare professionals is not always that. There is quite a policy implementation gap on that from that perspective. We also recognize that there are multiple ways that home-based records are used in maternal and newborn child health, and potential future uses could include expanded use, of course, the life course vaccination, for example, because we are now also having immunizations for adolescents, and so to look at how that could be included. new vaccines could be incorporated, potentially maybe even looking at the response that we're going to have, or the immunization response in relation to COVID-19 could be something. So future kind of thoughts, but also to make sure that self-care, family care, and self-monitoring is really going to be part of that. Then we also want to look at how digital home-based records can be integrated with health management information systems. And I think we've just had a couple of suggestions around that in the chat. Some people have also highlighted how the unique identifier could be used for that. And thirdly, the issue about global coordination, because I think that really struck me quite a lot, that, you know, one is we have fragmentation. We have many partners who feel that home-based records are important. They're all providing their support, but it's maybe not coordinated in the best manner at country level, and it results in more fragmentation rather than unifying around a national home-based record that could be linked to a national health information system. And so this, there are challenges around that. And so it would be important to really look at how to reduce that fragmentation and to see what kind of solutions we can have to scale up, let's say, home-based records. And maybe one thing that we could really think about that is to see how we can raise the importance from a policy perspective of the use of the home-based record. I think, first of all, it's important to look at integration to have an integrated home-based record. So across the life course, that might be one way to raise the perspective or the importance of the home-based record within the national policy dialogue, and to make also sure that we have the different partners around that in order to really also have cost efficiencies amongst support from partners in implementing and in supporting home-based records, as well as from the national level to have cost efficiencies around that. And that brings me also to the point around the research agenda around this. I think it would be important really to have an implementation research agenda around a number of the issues that we have raised today, to make sure also that we can look at the impact of the home-based records, because I think we have seen, based on when the guidelines were developed, that we have not always had evidence to really show what the impact is of the home-based records, and that this might be something that we can maybe put a bit higher on the agenda as well, so that policymakers really support this and will make sure that there are no stockouts, that we can take it forward from a digital perspective and link it really up with digitalization of healthcare, and look also at wider policies to break the digital divide as well. So we've gone a few minutes over time. I'm very sorry about that, but thank you all very much for having been with us for the last 2 hours. And I hope that we have identified a couple of practical things to move forward. Thank you.
Thank you so much, Anshu, and thank you to all the speakers for participating. And I hope you all have a good day. I'm going to be ending the session now. See you. Bye.
Bye.